Good afternoon and welcome to today's webinar, Thyroid Dysfunction in Pregnancy and its Effects on Neonates. I am Lisa Dunay and I'll be your moderator for today's event. Today's webinar is part of the Healthy Mother, Healthy Baby Thought Leadership Series, supported by a generous grant from Siemens Healthineers. AACC has partnered with Siemens Healthineers to bring you this webinar series, which will continue throughout 2019. As a global leader in medical technology, Siemens Healthineers is a trusted partner focused on the unique journey from preconception to pregnancy through neonatal care, delivering the clinical tools essential for healthy mother and baby outcomes. This program is accredited for Accent Continuing Education credit. Please note that this webinar has been previously recorded and can be stopped or paused at any time. So again, we thank you for joining us in today's Siemens Healthineers Thought Leadership webinar, Thyroid Dysfunction in Pregnancy and its Effects on Neonates. Our speaker is Dr. Linda Rogers. She is a board-certified clinical chemist who has held many laboratory director positions in Chicago, Ohio, Florida, and currently in Oregon. She has also held multiple positions in the laboratory diagnostics industry, including clinical and scientific affairs. Dr. Rogers' areas of special interest and expertise are in the fields of cardiac markers, endocrinology, maternal-fetal medicine, and women's health. She has presented papers, spoken at symposia, and organized programs for national and international meetings. Dr. Rogers is currently an independent consultant. Dr. Rogers, you may now begin your presentation.
Thank you, Lisa. And good afternoon, and thank you for joining this presentation on thyroid disorders in pregnancy and effects on the neonate. The agenda for today will begin with an overview of the thyroid endocrine system and the primary disorders of the thyroid, which is hypothyroidism and hyperthyroidism. Then I'll go into changes in the thyroid and thyroid function tests specific to pregnancy and discuss hypothyroidism and hyperthyroidism in pregnancy, and finally talk about the congenital effects on the neonate and fetus in hypo and hyperthyroidism. Thyroid dysfunction is very common and in the United States affects 27 million Americans. It's the most common endocrine disorder, even more common than diabetes. In pregnancy, thyroid dysfunction affects approximately 10 to 15% of all pregnant women. The most common dysfunction is subclinical hypothyroidism that affects between 3 and 5% of pregnant women. Overt hypothyroidism affects about 1%, and hyperthyroidism, although less prevalent, affects 0.1 to 0.4% of all pregnancies. Thyroid hormones are essential to all functions of the body and thus are particularly important in the pregnant women as we're dealing with both the mother and the baby as well. Thyroid hormones alter gene expression and protein production, regulate metabolism, protein, fats, and carbohydrates, and are in particular essential for normal development of the fetus and newborn brain and somatic tissue. So thus an emphasis on thyroid function and pregnancy. The normal thyroid endocrine system begins in the brain with the hypothalamus, which secretes thyroid-releasing hormone, acting on the anterior pituitary to produce thyroid-stimulating hormone, which in turn acts on the thyroid gland to produce thyroid hormones T3 and T4. These hormones all interact with each other to provide a feedback mechanism to regulate thyroid function in the body. TSH secretion increases when thyroid hormones are low and decreases when thyroid hormones are high. The two most common forms of thyroid disease are hypothyroidism, which is simply insufficient thyroid hormone and can be overt or subclinical, and hyperthyroidism, which is simply excess hormone, which also can be overt or subclinical. Hypothyroidism is most common in women. Age is a risk factor, with thyroid function decreasing with age, commonly occurring at around age 50. Another risk factor is family history of thyroid disorders and other autoimmune diseases. The symptoms of hypothyroidism are nonspecific, including fatigue and muscle weakness, hair loss and dry skin, but also related to the other endocrine systems and functions of the body, which are influenced by thyroid hormones, including the central nervous system, where there may be symptoms of impaired memory, learning, mental disturbances such as depression and sleep disturbances, the GI system with alterations in appetite and constipation, metabolic effects such as weight gain, and also effects on the reproductive system with impaired fertility and menstrual disturbances. The impact of hypothyroidism can be significant, and long-term effects can be very serious. One of these is myxedema coma. This is a potentially life-threatening condition, which is a complication of long-term hypothyroidism. Although it's very rare, mortality rates can be as high as 25 to 70%, and consists of extreme hypothermia resulting in coma. Other long-term effects include cardiovascular disease or dysfunction, including increased cholesterol levels or other forms of impaired cardiac function, including decreased cardiac output. To evaluate hypothyroidism in a patient with symptoms, first is a comprehensive physical exam, followed by laboratory diagnosis, beginning with TSH and followed by other thyroid function tests as needed. If there's additional abnormalities felt or seen with the thyroid gland, imaging may be necessary for further evaluation. The diagnostic algorithm for hypothyroidism begins with a TSH level. If this is normal, no further testing is needed. But if high, then a free T4 is ordered. If a free T4 is high, a rare condition can be diagnosed to central hypothyroidism or thyroid hormone resistance. But more commonly, the free T4 is low, indicating overt hypothyroidism. If free T4 is normal, yet TSH is elevated, this indicates a condition called subclinical hypothyroidism. So an overview of overt hypothyroidism TSH is elevated, total or free T4 is low, as is total or free T3, and antibodies may or may not be present. Structural abnormalities may be diagnosed with a thyroid scan or ultrasound. In subclinical disease, despite an elevated TSH, thyroid hormones are normal. Thyroid antibodies, however, may be present. Of particular importance is thyroid peroxidase antibody, abbreviated anti-TPO. With these antibodies present, progression to overt disease is much more common and may occur in 3 to 20% of cases. Next, we'll discuss hyperthyroidism. The risk factors for hyperthyroidism include female sex, age. The incidence is most common between 40 and 69, family history of hyperthyroidism, thyroid gland inflammation or existing goiter or enlargement of the thyroid gland, excessive thyroid hormone replacement therapy for hypothyroidism, other autoimmune diseases, and also smoking is a risk factor. Again, with hyperthyroidism, symptoms tend to be nonspecific. They can relate to the central nervous system with nervousness and irritability, mental disturbances such as anxiety, sleep disturbances including insomnia, reproductive issues, menstrual disturbances, and impaired fertility, and other issues related to metabolism such as weight loss, alterations in appetite, or GI effects. There are several long-term and serious complications of hyperthyroidism. The most important of these is a condition called thyroid storm, which involves very high levels of thyroid hormone resulting in confusion, psychosis, and even convulsions and coma. Hypothermia may be present as well as GI effects such as nausea, vomiting, and diarrhea. Cardiovascular effects such as tachycardia, hypertension, hypotension, and ultimately cardiac collapse and heart failure. This condition is very serious and requires immediate therapy, and even with therapy, the mortality may be as high as 20 to 50%. Cardiovascular disease is also a long-term complication with hypertension and ultimately congestive heart failure. Bone formation may also be altered, resulting in osteoporosis. To evaluate hyperthyroidism begins with a comprehensive physical exam by a physician, laboratory diagnosis with TSH and other thyroid function tests as needed, and often imaging if thyroid enlargement is present. I'm going to talk about the most common cause of hyperthyroidism, which is Graves' disease, because of its importance in both the mother and also the fetus and neonate as well. As I mentioned, it's the most common cause of hyperthyroidism with the incidence of about 1 in 200. It's 8 times more common in women than men. Symptoms are those of hyperthyroidism, including anxiety and irritability, tremors and weight loss, heat sensitivity, and menstrual abnormalities. A condition that may occur is with the eyes, in which the eyes appear to bulge. This condition is called ophthalmopathy. It occurs in about 30% of patients with Graves' disease and may occur even without other symptoms of hyperthyroidism. Graves' disease is an autoimmune disorder and results from autoantibodies called thyrotropin receptor antibodies, which override regulation, resulting in excess thyroid hormone. The treatment of this disease is surgery or radioablation to remove the thyroid gland or antithyroid drugs. Common manifestations of Graves' disease are enlargement of the thyroid, forming what is called a goiter, which is usually symmetrical and firm to the touch. As I mentioned, bulging eyes or ophthalmopathy is also often a symptom of Graves' disease, in addition to increased respirations and heart rate. The diagnosis of Graves' disease begins with TSH, and it's important to differentiate Graves' disease from other conditions where TSH is also depressed, including non-autoimmune hyperthyroidism, T3 toxicosis, or subclinical hyperthyroidism, in which all of these show a depressed TSH. With T3 thyrotoxicosis, free T3 is elevated where free T4 is normal. In non-autoimmune hyperthyroidism and Graves' disease, TSH is depressed, but thyroid hormones are elevated. And in subclinical hyperthyroidism, TSH is depressed, but thyroid hormones remain normal. To differentiate Graves' disease, one must run a test for autoantibodies. These autoantibodies, called thyroid receptor antibodies, can be measured with an assay for these called TRAB assays, or measure thyroid-stimulating autoantibodies or immunoglobulin directly. In Graves' disease and often thyrotoxicosis, these autoantibodies are positive. So a diagnostic algorithm for hyperthyroidism, again, begins with a TSH, and if normal, no further testing is necessary. If TSH is low, a free T4 or total T4 is run. If normal or decreased, then free T3 or total T3 is ordered, and if elevated, indicates T3 thyrotoxicosis. If T3 is also normal, despite a low TSH, then it's recommended to retest in several months. If TSH is low and free T4 or total T4 are elevated, then it's necessary to test for autoimmune disease, as I mentioned, either TRAB assays or an assay for thyroid-stimulating autoantibodies or immunoglobulin called TSI. Anti-TPO also may be ordered at this time. With normal TSH activity, TSH normally binds to the TSH receptor on the thyrocyte, upregulating the production of thyroid hormones T3 and T4. In Graves' disease, autoantibodies may be stimulating, which bind to the receptor on the thyrocyte and also upregulates the production of T3 and T4. In rare occasions, these autoantibodies may actually be blocking antibodies that bind to the receptor, blocking the binding of TSH, and inhibit the production of T3 and T4, causing hypothyroidism rather than the typical hyperthyroidism seen in Graves' disease. Just to review the nomenclature of these autoantibodies, a general term is called TRAB, thyroid receptor antibodies. These antibodies may either inhibit or stimulate the production of thyroid hormones. They may be blocking antibodies that depress the production of T3 and T4, resulting in hypothyroidism, or more frequently be stimulating antibodies that stimulate the production of thyroid hormones, resulting in the typical hyperthyroidism of Graves' disease. There are numerous assays available to test for these autoantibodies. Most of these assays, including the more common TRAB assay, measures or can react with both blocking and stimulating antibodies. The assay for thyroid stimulating immunoglobulin is more specific for the stimulating autoantibodies. To illustrate the importance of measuring these autoantibodies in Graves' disease, this is a list of utilization of these antibody tests. First of all, it's important for the differential diagnosis of Graves' disease, differentiating it from other causes of hyperthyroidism. Important in the condition known as ophthalmopathy to identify the cause of this condition and also to guide treatment, as radioablation therapy is contraindicated in this condition, making it even worse. In pregnancy, these autoantibodies are very important to differentiate Graves' disease from other causes of hyperthyroidism, of which I'll discuss in later slides. It's also important in pregnancy to guide treatment and also in the hyperthyroidism resulting from Graves' disease in the neonate, and to help diagnose and manage treatment. The thyroid gland changes significantly in pregnancy, and I'll discuss some of these changes and their effects on thyroid function tests. First of all, as pregnancy occurs, the hormone human chorionic gonadotropin increases, as you can see in this chart. As HCG increases, TSH actually declines, and this is due to the weak thyroid stimulating effect of HCG. This is prevalent in the first trimester of pregnancy and returns to normal in the second and third trimester. This transient period of hyperthyroidism that's normal in pregnancy during the first trimester is called gestational transient thyrotoxicosis. Due to this normal condition of pregnancy and the resulting changes in TSH, most organizations, such as the American College of Obstetrics and Gynecology, American Thyroid Association, and American Association of Clinical Endocrinologists, all recommend the use of trimester-specific reference ranges for TSH. There are additional effects of the thyroid gland resulting from pregnancy. One of these is the rising estrogen levels, which stimulates the production of thyroid binding globulin. This binding globulin binds to both T3 and T4, and as you know, only free hormone is active. In order to maintain adequate free thyroid hormone concentrations, as the production of this globulin increases, the production of T3 and T4 also increases. So total T3 and T4 concentrations rise during the first half of pregnancy to about 1.5 times pre-pregnancy levels and plateau at approximately 20 weeks until a steady state is reached, and then return to pre-pregnancy levels. The American Thyroid Association guidelines, most recently published in 2017, also recommends using pregnancy-adjusted total T4 measurements and also suggests that total T4 is a more reliable test than free T4 during pregnancy. So to review the physiological changes and the resulting changes in thyroid function tests, the binding protein TBG increases during pregnancy, and this increases both total T3 and total T4. The elevation of HCG, particularly during the first trimester, decreases TSH due to its stimulatory effect on the thyroid. Thyroid enlargement increases serum thyroglobulin production, and in addition, iodine clearance through the kidneys is increased, and this can decrease production of thyroid hormones if iodine is deficient. Therefore, most organizations do recommend iodine supplementation during pregnancy. Most organizations also recommend, as I mentioned, trimester-specific reference ranges for TSH. The chart listed shows the trimesters and TSH recommended ranges that have been in place for many years and are common through most organizations. The one difference is the American Thyroid Association's most recent guidelines in 2017, which recommends an increase in the upper limit of normal to 4 milli-international units per liter. Thus far, this is the only organization that have changed these trimester-specific reference ranges. So laboratories should have trimester-specific TSH reference ranges in place and may want to check with their physicians for their recommendations. Thyroid function in pregnancy has many changes, and the universal screening of thyroid function in pregnancy has been controversial. Many studies have been performed to look at the advantages and disadvantages of requiring thyroid function to be tested in all pregnant women. But due to conflicting evidence, most organizations thus far are not endorsing universal screening. However, they do recommend testing in pregnant women with the following indications. And there are many indications for thyroid testing in pregnancy. So many women are tested beginning with a TSH level in pregnancy. And these indications include being on thyroid supplementation, having a history of thyroid dysfunction, or current symptoms or signs of thyroid dysfunction, having a family history, or having any autoimmune disease or a family history of autoimmune diseases, known antibody positivity, any symptoms of enlarged thyroid like a goiter present, being over the age of 30, any history of head or neck radiation or prior thyroid surgery, and many other indications listed here, including a history of miscarriage, preterm delivery, or infertility. As I mentioned, thyroid function does influence the reproductive system, and these are all symptoms of thyroid dysfunction. Other indications are multiple prior pregnancies, morbid obesity, certain drugs, or residing in an area of known iodine insufficiency. This slide just shows the thyroid function test changes in a normal pregnancy and as opposed to hypo and hyperthyroidism. In normal pregnancy, TSH decreases, T3 and T4 increase, and there is no change usually in free T4. In hypo and hyperthyroidism, the changes in pregnancy are seen as in any other non-pregnant person suffering from these diseases. These are not any different. I'll begin with a discussion of hypothyroidism in pregnancy. And as I mentioned, the average incidence of hypothyroidism in the U.S. is 2.5%, and subclinical hypothyroidism 3 to 15%. Overt hypothyroidism is seen in about 1% of pregnancies. In iodine-deficient countries and worldwide, the most common cause of hypothyroidism in pregnant women is iodine deficiency. As the fetus gets its iodine from the mother, maternal iodine deficiency not only affects the mother's thyroid function, but also the fetus. In iodine-sufficient parts of the world, including the U.S., the most common cause of hypothyroidism is an autoimmune disorder known as Hashimoto's disease. And the treatment for hypothyroidism is very important in pregnancy, as the fetus is dependent on maternal thyroid hormones for the first trimester. As I mentioned, Hashimoto's thyroiditis is the most common cause of hypothyroidism in pregnancy in iodine-sufficient parts of the world. The cause of Hashimoto's disease is autoantibodies. It is an autoimmune disease. The antibodies attack the thyroid gland, resulting in inflammation. This inflammation is known as chronic lymphocytic thyroiditis, causing inflammation of the thyroid gland and ultimately dysfunction and decreased production of thyroid hormone. Symptoms and treatment are the same as those for any other form of hypothyroidism, which is replacement of thyroid hormone with levothyroxine. Risk factors are increasing age, the female sex, hereditary predisposition, and the presence of any other autoimmune disorders. The diagnosis is the presence of TPO antibodies in addition to the elevated TSH and decreased thyroid hormones. And it's important to note that TPO antibodies, as other antibodies, can cross the placenta, resulting in abnormalities in the fetus and the neonate. Complications of hypothyroidism in pregnancy are both mother and neonate. Maternal complications include miscarriage, anemia, pre-eclampsia, which is a serious condition resulting in hypertension and kidney dysfunction in the mother, placental abruption, and postpartum hemorrhage. Neonatal complications include premature birth, low birth weight, increased neonatal respiratory distress syndrome, and most importantly, severe cognitive, neurological, and developmental abnormalities, which are prevented with treatment. The treatment of overt hypothyroidism is simply replacement of thyroid hormone with levothyroxine. The treatment goal is to maintain serum TSH levels less than 2.5 milli-international units per liter. And measurement of TSH is important for management. It's necessary every 4 to 6 weeks until at least 24 weeks or until stable. And then again at 24 to 26 weeks of pregnancy and right before birth at 32 to 34 weeks. So the laboratory plays an important role in the management of thyroid disease and pregnancy. Treatment of subclinical hypothyroidism in pregnancy differs from that in non-pregnancy. In non-pregnancy, usually there is no treatment that's recommended by organizations. But in pregnancy, depends both on the level of TSH and the status of TPO antibodies. If TPO antibodies are positive and TSH levels are greater than 2.5, then levothyroxine is prescribed. The treatment goal is to keep levels between or less than 2.5 milli-international units per liter, continued measurement of TSH until stable, and then again at 24, 26 weeks and right before birth. If TPO antibodies are positive and TSH levels are below 2.5, then no treatment is recommended by most organizations. However, if TSH levels are greater than 10, even if TPO antibodies are negative, thyroxine is recommended, and treatment goals and monitoring is the same as for if TPO antibodies are positive and TSH levels are greater than 2.5. Hyperthyroidism in pregnancy is less common than hypothyroidism and occurs in only about 0.1 to 0.4% of all pregnancies. The most common cause during pregnancy is the autoimmune disorder Graves' disease. As I mentioned, in the first trimester of pregnancy, a transient form of hyperthyroidism is present called gestational transient thyrotoxicosis, which is self-limited and usually returns to normal after the first trimester. However, if hyperthyroidism continues, it's important to differentiate the cause of this hyperthyroidism, as hyperthyroidism is associated with an increased risk of severe pre-eclampsia for the mother and up to 4-fold increased risk of low birth weight deliveries, in addition to hyperthyroidism affecting the neonate. Gestational transient hyperthyroidism, as I mentioned, is self-limited and due to the stimulatory effects of beta-HCG. During this period, antithyroid drugs are not recommended. Sometimes a condition of excessive vomiting occurs called hyperemesis gravidarum, but even in this condition, antithyroid drugs are not recommended, only supportive therapy and measurement of dehydration. If hyperthyroidism continues, it's very important to distinguish Graves' disease from other causes of hyperthyroidism with the measurement of thyroid-stimulating immunoglobulins or TRAB assays. Complications of hyperthyroidism in pregnancy occur both in the mother and the neonate. Maternal complications include thyroid storm, which I mentioned is a medical emergency, miscarriage, anemia, pre-eclampsia, placental abruption, and postpartum hemorrhage. Neonatal complications are premature birth, low birth weight, increased respiratory distress syndrome, stillbirth, congenital malformations, and fetal tachycardia, in addition to hyperthyroidism of the neonate. Treatment of hyperthyroidism in pregnancy due to Graves' disease is the same as in non-pregnancy, and this is with antithyroid drugs, methimazole or propylthiouracil. The treatment goal is to keep thyroid or T4 in the upper third of the reference range and to measure TSH and total T4 every 2 weeks until stable, and then measuring weekly beginning at week 32 to 34 before birth. So again, laboratory is very critical in the management of Graves' disease during pregnancy. The measurement of autoantibodies in Graves' disease is particularly important in pregnancy. It's important in women who are currently on antithyroid therapy to measure the amount of autoantibodies and to determine how effective the therapy is. Even in women who have had treatment prior to pregnancy with radioactive iodine ablation or surgery may continue to have these autoantibodies in their circulation, and these autoantibodies will pass through the placenta and on into the neonate. And also if they have previously had children with neonatal hyperthyroidism. So it's important to test the neonate, particularly if the mother's autoantibody levels by TRAB assays or TSI assays are high in the third trimester. There's another condition that occurs in pregnancy called postpartum thyroiditis. This is a temporary condition and results from inflammation of the thyroid gland after delivery. It's a fairly prevalent condition, averaging about 7.5% of all pregnant women. The cause is thought to be autoimmune, as TPO antibodies are almost always positive. The typical course begins with a transient hyperthyroidism, which occurs approximately 1 to 3 months post-delivery, and then is followed by a period of hypothyroidism, which can last up to 8 months or longer. But it's important to note that antithyroid drugs are not recommended for use in the hyperthyroidism phase, as it is temporary, but levothyroxine may be prescribed if the hypothyroidism is severe and if it continues beyond 8 months after delivery. The fetus and neonate are very dependent on thyroid hormones from the mother, and this is particularly important in the first trimester. The first trimester is when the thyroid gland of the fetus develops. So for the first 10 to 12 weeks, the fetus is dependent on maternal thyroid hormones. The fetus begins producing thyroid hormones from its developed thyroid gland at about 12 weeks of gestation. The fetus also remains dependent on the mother for adequate iodine throughout pregnancy. So thyroid status is influenced by maternal thyroid function. Both thyroid antibodies and thyroid drugs do cross the placenta. TSH, however, does not cross the placenta, and thyroid hormone tends to be variable. But as I mentioned, the fetus is dependent in the early weeks of pregnancy. Congenital hypothyroidism, where deficiency is present at birth, can be permanent, but most often is transient. The cause can be thyroid gland abnormalities, iodine deficiency, which is why iodine supplementation is recommended in pregnancy, or an inborn error of metabolism. Mental retardation and cognitive disorders is the highest risk of congenital hypothyroidism, but is totally preventable with therapy. The incidence of congenital hypothyroidism ranges from 1 in 800 to 1 in 10,000. It's important to treat hypothyroidism as soon as possible. And this is a statement from the American Thyroid Association's most recent guidelines. Congenital hypothyroidism is one of the most frequent treatable causes of intellectual impairment, and newborn screening for the detection of congenital hypothyroidism is performed routinely in all 50 states of the U.S. It's very important for screening to occur in all newborns to avoid these neurocognitive deficits, which again is totally treatable and eliminated by treatment with levothyroxine. As I mentioned, congenital hypothyroidism is the most treatable cause of intellectual impairment, and newborn screening for congenital hypothyroidism is performed by all states, although the extent of screening tests differ by state. All states, however, do perform a TSH, and this screening should be performed within several days of birth. And again, another statement from the American Thyroidism in which this newborn screening has led to the virtual elimination of intellectual impairment due to hypothyroidism. Treatment is with thyroid supplementation using levothyroxine. Congenital hyperthyroidism involves excess thyroid hormone that's present at birth. Although the prevalence is rare, only about 0.01% of pregnancies, it can be a very serious condition in the neonate and must be treated. Fetal complications include preterm delivery, growth restriction, and even death of the neonate. The most frequent cause of hyperthyroidism in the neonate is maternal Graves' disease. As I mentioned, maternal autoantibodies and antithyroid drugs both readily cross the placenta and enter the neonate circulation. The higher the level of these autoantibodies, the higher the risk for poor outcomes in the neonate. Severe hyperthyroidism in newborns can be life-threatening, and treatment and follow-up and management with thyroid function tests and anti-thyroid medication is essential. Thyroid function tests need to be monitored, as well as the autoantibodies with either TSI or TRAB assays. This form of hyperthyroidism may be temporary in the neonate, as the maternal autoantibodies do clear from the neonate circulation in several months. This chart just shows the diagnosis and monitoring of fetal and congenital hyperthyroidism, both in the mother and in the neonate. And again, very important to monitor frequently the levels of TSH and T4, usually every 4 to 6 weeks. And the measurement of thyroid stimulating antibodies with either TSI or TRAB assays is critical for both the diagnosis and also the follow-up of neonates. Some guidelines even recommend the measurement of these autoantibodies immediately at birth in cord blood so they can begin treatment with antithyroid drugs. So to review congenital hypothyroidism, a high titer of these autoantibodies measured by TRAB or TSI assays measured late in pregnancy can predict the risk of intrauterine or neonatal thyrotoxicosis or hyperthyroidism. The higher the level of these autoantibodies, the more likely the neonate will suffer from severe hyperthyroidism. Early diagnosis of neonatal hyperthyroidism involves measurement of TSH, thyroid hormones, and also the autoantibodies in the neonate of the mother with Graves' disease. The neonate needs to be treated immediately with antithyroid drugs. Improvement is usually rapid. Autoantibodies need to be measured periodically. They do clear from the neonatal circulation, usually after about 12 weeks. But meanwhile, testing regularly with TSH and free T4 in the neonate is necessary to guide treatment with antithyroid drugs until the neonate is no longer hyperthyroid. So to summarize this presentation, thyroid disease is very common in the population and also in pregnancy, and is a very common clinical problem. Pregnancy itself has significant effects on the thyroid gland of the mother, with resultant changes in thyroid function tests, which all laboratories and physicians need to be aware of. Highly recommended by all organizations to use trimester-specific reference ranges for thyroid function tests, specifically TSH and total T4. Thyroid disorders can result in serious maternal and neonatal complications. Treatment during pregnancy is essential to minimize both the maternal complications and neonatal complications, and this treatment may differ from treatment in non-pregnant women. Thyroid testing and treatment for dysfunction is essential for neonates born from mothers with thyroid disease, both hypothyroidism and hyperthyroidism, as both drugs and antibodies cross the placenta. The following is a list of references for more information, including guidelines from ACOG, the ATA, and other agencies. And Now I'll be happy to answer any questions that you may have.
Thank you, Dr. Rogers, for sharing that excellent presentation with us. So we will now begin the Q&A session, which includes questions that were previously submitted. And the first question is, what is included in the universal testing protocol for pregnant women?
Universal screening would involve testing every woman that becomes pregnant with thyroid testing or thyroid function tests, beginning with TSH and other thyroid function tests as needed. This universal screening is controversial because of the fact that many clinical studies have been performed to determine the benefits of universal screening, and there's no true conclusions that have been reached. So thus far, no organizations do recommend universal screening, although they do recommend screening for any woman that has any indications that I have listed on a previous slide.
Thank you. And the next question is, in the United States, there are universal screening protocols for the screening of hyperthyroidism in neonates. So are there also similar protocols for screening of hyperthyroidism in newborns?
The current neonatal screening always involves a TSH level. And TSH level in general is looking for hypothyroidism, which is most common, so that neonate can be treated with levothyroxine and eliminate the potential for neurocognitive disorders. But if that TSH is also low, that can indicate further testing is needed for hyperthyroidism. So although much more rare, this condition can also be identified with neonatal screening.
Thank you, Dr. Rogers. Well, that concludes the Q&A session. So I want to thank you again for joining us today and giving that presentation. And I'd also like to thank all of you in the audience for listening to this Semen Healthy News Thought Leadership webinar. To claim your Accent Continuing Education credit, please refer back to the email with the recording of this webinar and click on the link provided for CE credit. I'd also like to point out that a recording of this webinar will be posted on the Thought Leadership Series page on AACC's website. And on this page, there will be an archive of all the webinars in this series if you would like to view others that you may have missed. So thank you again, and we hope you have a wonderful rest of the day.